in terms of the trials, and this year we got even more. So we selected about 7 out of 14 or 15, all of which were really good abstracts and trials. Had to make very difficult decision in terms of picking some. And so we're going to have oral presentations for those today, but the others are available on the poster and in the web. So I think with that, I'll turn this over to Naomi to start introducing the speakers. We're going to try and have the presentations limited to about 4 or 5 minutes, and then if we have time for maybe one question, but we really want to have some questions at the end of the discussion at the end of the session, including if you have a trial that you want to speak to or make us aware of. We'll use that time for that. Naomi?
Okay, so we're going to start with Michael Serzan, who is from the Dana-Farber Cancer Institute, and he's going to talk about the ARCITECT trial.
Thank you. So thank you, Bob, Naomi, and KCRS for the opportunity to present the ARCITECT study on behalf of my co-investigators. To me, no single drug has made a bigger impact in the treatment of patients with kidney cancer than targeting PD-1. We saw it first in the second-line setting. We've seen it in the front-line metastatic setting in combination regimens, and most recently, we've seen it in the adjuvant setting. But many in this audience know that far too few patients garner long-term durable benefit from our current anti-PD-1 combination therapies. And so what ARCITECT is investigating is what are the particular resistance mechanisms to anti-PD-1 therapy, and what is a way that we can effectively target those resistance mechanisms to induce more long-term durable remissions for patients with clear cell kidney cancer. As background for this study is, I think, a great example of translational research. So what we're learning in the lab being translated into how we're treating patients in the clinic. At KCRS last year, we learned from Sabina Signoretti that regulatory T cells are a critical resistance mechanism to anti-PD-1 therapy, such that when you give an anti-PD-1 based drug to a Treg that expresses PD-1, it can reactivate that regulatory T cell and therefore lead to immune suppression in the tumor microenvironment. In the clinic, we've identified a new checkpoint inhibitor called botensilimab, which is an Fc-enhanced CTLA inhibitor that on the front end of the molecule recognizes CTLA, which is constitutively expressed on Tregs, but on the back end of that molecule, it brings NK cells in close proximity to those Tregs and thereby leads to their depletion in the tumor microenvironment. This drug has been investigated in combination with balstilimab, which is a PD-1 inhibitor from a company called Agenus, and we've seen responses in immunologically cold tumors, such as microsatellite stable colon cancer, where previous immune checkpoint inhibitors like ipilimumab plus nivolumab have had historically poor responses. And so our hypothesis is that if Tregs are critically important in clear cell kidney cancer, and botensilimab and balstilimab is working in immunologically cold tumors, then it ought to work even better in clear cell kidney cancer. And so with this in mind, we designed the ARCITECT study, which is a randomized phase 2 investigator-initiated trial for patients with advanced or metastatic clear cell kidney cancer. We're accepting patients with all IMDC risks, so favorable, intermediate, and poor risk disease. Patients who have received prior adjuvant therapy are not eligible to be on protocol, and patients have to have a biopsy of a metastatic lesion within 12 months of starting protocol therapy. It's a study of 120 patients with a 2-to-1 randomization, so about 80 patients will be randomized to Arm A, which is botensilimab plus balstilimab. You'll note that the induction schedule is a little bit different than Nivo-Ipi, so it's 2 doses of the combination botensilimab plus balstilimab followed by PD-1 alone. At that 12-week mark, so at that first scan, if patients are having stable disease or better and are tolerating therapy, they can then get additional doses of botensilimab plus balstilimab as in the maintenance phase. In the non-comparative controls, so 40 patients will be randomized to nivolumab plus ipilimumab given at its approved dose and schedule. The primary endpoint of our study is going to be looking at response rate in the botensilimab plus balstilimab arm. We're targeting a response rate of 55% with a null hypothesis of 40%. Secondary endpoints we're looking at are duration of response, progression-free survival, treatment-free survival, as well as toxicity. And then we have a host of correlative endpoints looking at does the improved efficacy that we see in this combination correlate with a high level of Tregs at baseline. Our study is currently open at 10 sites. We now have 9 patients enrolled. We're looking to ramp up, hopefully meet full accrual within the next 12 months. What is the potential impact of the ARCITECT study? Well, we believe that investigating novel immune checkpoint molecules in the frontline setting has the potential to improve long-term durable remissions for our patients with kidney cancer, and to take a note from Jim Allison's notebook, raise the tail on the PFS and OS curves. The ARCITECT study is the first investigation of botensilimab in clear cell kidney cancer, and if successful, will hopefully build on larger randomized phase 3 trials, as well as investigating Treg depletion in the second or later line setting. There's some very rich biomarker work being done by David Braun in his lab at Yale, as well as Sabina Signoretti in her lab at Dana-Farber, which will hopefully help us understand more about kidney cancer. To close, I have to express my immense gratitude to Dr. Atkins, who has been a fantastic mentor and a real visionary leader with this protocol, and as well as everybody else who's listed on the slide here. So with that, I'll close and thank you all for your attention.
I think we'll go on to the next first and save questions for last. So the next is Rana McKay from UCSD, and she's going to talk about, I'll let her show her first slide in the interest of time.
So happy to discuss this phase 1 study of HC7366 in combination with Belzutifan in patients with renal cell carcinoma. GCN2, which is a general controlled non-derepressible 2. This is a kinase, it's a serine threonine kinase that's actually responsible for augmenting the stress response within the cell. It's a metabolic sensor of the stress response, and HC7366 is an activator. It's a first-in-class activator of this pathway. This is a novel pathway. Its activation actually results in apoptosis within the cell and cell cycle manipulation. HC7366 has demonstrated activity in Belzutifan-resistant cell lines and actually has potentiated the activity of Belzutifan within preclinical models. It has a multifaceted mechanism of action. In addition to augmenting the stress response within the cell, it reduces HIF-1 alpha and HIF-2 beta levels within the cell. It inhibits cell cycle pathway, and it also reduces immunosuppressive cells within the tumor microenvironment. The phase 1 first-in-human study was conducted demonstrating safety of the monotherapy with a signal of activity within renal cell carcinoma tumors, which is now being further investigated within a clinical trial that I'll highlight next. So this is the phase 1b RCC study enrolling patients with metastatic clear cell renal cell carcinoma that's post a checkpoint inhibitor and post VEGF inhibition. There will be 2 cohorts that will be enrolled. The monotherapy patients will be allowed to have received 1 to 4 prior lines of therapy and may have received prior Belzutifan or other HIF-2 alpha targeting agents. With regards to the combination, this is being looked at in combination with Belzutifan, giving the potential for synergy of these 2 agents. They are going to be Belzutifan naive. The sample size will be up to 80 patients. As you can see, the monotherapy will look at 60 milligram dosing, Q daily dosing of HC7366, whereas the combination will look at 20, 40, and 60 milligram dosing of HC7366. There'll be dose expansions following the escalation, particularly in the combination cohorts, looking at 2 different dose levels to potentially move forward. This study is being conducted across 20 different sites across the US. And then to highlight the significant vision and for this study and this new pathway, we know that renal cell carcinoma is a metabolic disease. It's driven by HIF dysregulation. It's exciting that Belzutifan has entered into the clinic, but we've all seen that there's definitely still an unmet need with regards to building on the activity of Belzutifan. HC736 activates GCN2, which is a core regulator of the metabolic stress response, again, inhibiting cell cycle, reducing HIF alpha levels, and reducing the immunosuppressive cells that are within the tumor microenvironment. We've demonstrated preclinical activity of HC7366 monotherapy in Belzutifan-resistant cell lines and deepening those responses with Belzutifan and favorable safety profile in a original phase 1A study. And now we're moving on to this phase 1B, looking at safety, MTD, the recommended phase 2 dosing, and also initial signal of early efficacy. That's all I got.
Thank you, Rana. Okay, next is Pavlos Msaouel, who's going to talk about Ubamatamab in MUC16 expressing SMARCB1 deficient renal medullary carcinoma and epithelioid sarcoma. Thank you.
Thank you for the opportunity to talk about this trial. These are my disclosures. We're doing this trial in collaboration with Regenerative Pharmaceuticals. And renal medullary carcinoma, as many of you know, is defined by loss of the SMARCB1 tumor suppressor in 100% of cases. And it is a very, very deadly kidney cancer with a median survival when it was first described of just 4 months from diagnosis, regardless of stage, et cetera. By 2017, the median survival was 13 months. And then last year in the AACR Kidney Cancer Conference, we set up the specific benchmark goals so that we have milestones for our patients, our researchers, and our funders to be accountable for, that we're going to get the 2-year survival, the survival by 2025 to 2 years. And they thought, initially that we're crazy, but then we explained how we're going to do it. And here you can see that we are reaching this milestone very well. 126 patients at one institution. We see about 5 to 8 patients with RMC per week. And you can see how the 2-year survival outcomes have accelerated the improvement in their outcomes. We also said that we're going to get the median survival to 5 years by 2030, and I'm going to show you today one avenue that could help get us there. Another cancer, this is a good example of how now this RMC strategy may help other cancers, is epithelioid sarcoma, also deadly and also defined by the loss of the SMARCB1 tumor suppressor. And the outcomes remain poor even though tazemetostat, an EZH2 inhibitor, was approved for epithelioid sarcoma. Now, MUC16 is a molecule that is expressed on the cell surface of cells, and then it gets proteolytically cleaved, and you get this domain of it that is known as CA125 that gets released on the bloodstream. This is a marker that is used for various cancers, most commonly known for ovarian cancer. And it has been known for epithelioid sarcoma for about a decade. My partner in crime, Alex Lazaro, was one of the people that showed this, that epithelioid sarcoma expresses CA125 in 60 to 80% of cases. My lab subsequently shown that the same goes with renal medullary carcinoma. Between 60 to 80% of cases will express it, and it correlates very nicely with tumor burden. This is the first clinically validated serum biomarker for a kidney cancer used in practice. You can see here how very nicely the IHC findings for MUC16 correlate with serum CA125 levels. And my lab has shown, I'm not going to show you that data, that the SMARCB1 loss appears to be necessary but not sufficient for MUC16 expression. That's why some people do not express it. Now, the other thing that we have shown is that part of the reason why RMC is resistant to immunotherapy is because it downregulates MHC class 1. Stay tuned for that publication. And Ubamatamab is a bispecific that targets CD3 and MUC16, and thus replaces, bypasses signal 1. And also there is clinical evidence and preclinical evidence that the addition of PD-1 inhibition with drugs like cemiplimab may facilitate this T-cell activation. And there is a case example in Canada of a patient with SMARCB1 negative epithelioid sarcoma that achieved a durable, to this day, partial response to Ubamatamab monotherapy after disease progression on every other therapy, including tazemetostat and nivo-ipi. So with this in mind, we designed this trial that we hope to activate on September 1st of using Ubamatamab in patients with RMC and epithelioid sarcoma that have progressed on at least one prior therapy. We will enroll up to 20 patients for each disease cohort, and we're going to have two stages. One, we're going to test cleanly what Ubamatamab monotherapy does, and then for the ones that progress to the monotherapy, we're going to investigate what happens when we add cemiplimab. If they're already getting Ubamatamab, we'll just add cemiplimab immediately. If they're not, then what we're going to do is we're going to first prime them with Ubamatamab and then add cemiplimab. We're going to use the classic co-primary endpoints that we have been using in our prior RMC trials. This will be the fourth study that we're opening for renal medullary carcinoma, and this criteria has served us well to very quickly make go, no-go decisions based on these null hypothesis and alternative hypothesis with good type 1 and type 2 error operating characteristics. And of course, as always, while we're very excited about this trial, we're prepared for it if it is negative, and we will learn a lot, whether it's positive or negative, through our tissue and blood correlatives that we have, once again, incorporated throughout this trial. Thank you very much for listening to this, and happy to answer any questions you guys have.
Okay, next, Clara Steiner will be speaking about an implantable microdevice and she's from the Dana-Farber Cancer Center.
Thank you very much for the opportunity to present our microdevice trial. Unfortunately, Dr. Xu cannot be here today, so I'm going to present our study on behalf of my co-authors. To date, there are no personalized biomarkers that can guide treatment of renal cell carcinoma, and treatment decisions are based on clinical characteristics. Researchers from Brigham and Women's Hospital and Dana-Farber Cancer Institute have developed an implantable microdevice that can be placed into a target tumor percutaneously under imaging guidance. These microdevices can deliver up to 20 different drugs or drug combination into the tumor and allow assessment of tumor response to the drug in the patient's individual microenvironment. The main goal and question of this trial is to show if microdevice implantation in renal cell carcinoma is safe and feasible. To answer that question, we want to enroll 20 patients with a planned resection of either their primary tumor or a metastatic site of renal cell carcinoma. And microdevices are implanted into the target tumor 3 days prior to the resection. Depending on the tumor size, usually more than one microdevice is implanted into the tumor to account for tumor heterogeneity. On the left, you can see a schematic view of a microdevice and a sample loading diagram, and you can see that the substances are delivered in different directions. By the time of the surgical resection of the tumor, microdevices are retrieved together with the surrounding tumor tissue and processed for further analysis. The patient proceeds to their standard of care treatment and clinical follow-up. The images that you see on the top are taken from an RCC tumor from a patient who already underwent microdevice implantation and show a level with the delivery of pembrolizumab and abemaciclib in opposite directions. In the cyclic immunofluorescence image, you can see that pembrolizumab seems to cause an immune cell infiltration in contrast to abemaciclib. So if this technique is successful, microdevices could potentially allow to simultaneously evaluate multiple drugs in vivo and could be a useful approach for a personalized treatment. In the future, they might even allow to test substances without exposing the patient to systemic toxicity prior to phase 1 clinical trials. Thank you very much.
Okay, next is Toni Choueiri, who's going to talk about the INTERPATH 004 trial.
Thank you for having me. So, pleasure to present a study that just opening up in multiple places in the U.S. and outside the U.S. Interpath 004, which is a phase 2 randomized double-blind study of Pembro plus a vaccine, V940, also mRNA 4157, or placebo in the adjuvant treatment of renal cell cancer, a study being led by Bob Motzer and myself. So in terms of background, the PD-1 inhibitor Pembro, now we know, is approved for the adjuvant treatment of renal cell cancer, high-risk renal cell cancer, based on KEYNOTE-564, a disease-free survival and an overall survival advantage. How we can, add to that is by potentially an individualized neoantigen therapy. V940 consists of a lipid nanoparticle up to 34 neoantigen after sequencing the tumor and looking at the most immunogenic, neoantigen. These patients are re-injected with that product in addition to being on pembrolizumab. Here, the background is that this neoantigen therapy will enhance and increase the anti-tumor activity of T cell and enhance pembrolizumab activity. It's important to note that earlier work has started actually by Dr. Kathy Wu from Dana-Farber Cancer Institute. In her work, Dr. Wu, at that time, founding a company, doing her work, later acquired by BioNTech, which we know all the story with the COVID mRNA vaccine. At that time, Kathy and I, and with our mentee at that time, David Braun, had a study of over 12 patients with very high-risk renal cell carcinoma that was part of a very couple of large grants. And this study actually is in revision, third or fourth revision. So there's a precedent to this. Now, on the other hand, the same strategy here employed by Merck and their collaborator, the other RNA, I would say company, Moderna, proved to be of clinical value, definitely in a high-risk melanoma study led by Jeff Weber. This was a resected stage 3-4 melanoma, small randomized phase 2 that showed a disease-free survival advantage, I believe, at 2 time points. So this is our study. Think about KEYNOTE-564 criteria overall, patient with clear cell RCC at intermediate or high risk renal cell cancer. There are a couple of differences compared to original KEYNOTE-564. It's more closer to the eligibility of LITESPARK-022, so the M1 NED is up to 2 years, and for T3, we're allowing grade 3 and 4. Those are the very small differences in general. So those patients, after stratification according to histology and the disease risk, will be randomized 136 to pembrolizumab plus placebo or pembrolizumab plus the vaccine. As I mentioned, these are the eligibility criteria, very similar to KEYNOTE-564, almost identical to LITESPARK-022, which is the randomized phase 3 of Pembro plus minus the HIF2 inhibitor that finished accrual a couple of months ago. This is the schedule of assessment and follow-up. The primary endpoint, I didn't want to bore you with statistics, but the primary endpoint is disease-free survival with the traditional secondary endpoint in the adjuvant studies of OS and distant metastases-free survival. So hopefully this will be another strategy that will help our patient. So far we know that these vaccines given early on may have better tumor control and certainly less side effects in general. The study is currently open at multiple sites and enrolling patients, and hope this will be another successful study like in high-risk melanoma, bringing the vaccine to patients. And thank you.
And next is Grant Stewart from the University of Cambridge, who will be talking about the WIRE platform.
Thank you. So WIRE is a window of opportunity study in people who are having surgical resection for kidney cancer. So this study was born from the desire for patients for treatments whilst they're waiting for their operation. So in the UK, we have between 4 and 6 weeks between listing a patient for surgery and undertaking it, and that's a worrying time for patients. So they wanted trial options during that period of time. Along with that, we aim to establish a durable renal cancer trial and translational platform for investigating new agents and combinations of agents in our patients, and developed WIRE, which is the first phase 2 multi-arm, multi-center, non-randomized platform trial, and it uses a Bayesian design, which I'll show you in a moment. This is the trial schema, so patients who are operable, so that's quite a wide inclusion criteria, but essentially anyone who had T1B or above disease, N0, N1, M0, M1, who had clear cell renal cancer on biopsy, so we undertook a biopsy for both diagnosis but also for research tissues. Patients then had MRI scan, advanced cancer imaging techniques like hyperpolarized MRI as well. You can see the agents that are being evaluated in WIRE. We've completed the first 3 arms, which are all centered around the use of olaparib in one way or another, and we're about to start 2 bispecific immunotherapy arms. These are all AstraZeneca compounds at the moment, but this trial platform would be open to other partners. Patient has either, if they're on an oral regimen, between 2 and 4 weeks of treatment, so not increasing the length of time that they're waiting for surgery. If they're having an infusion, they would have 1 infusion. They then have MRI prior to the surgery, just in the days leading up to it, and then have their operation as normal. Obviously, it's a fairly short treatment time point, so we're not looking at the traditional endpoints, rather a series of surrogate endpoints. For the olaparib and cediranib containing arms, those are based around vascular permeability, measured on the MRI scan, so that's an assessment called K-trans. For the bispecific immunotherapies, an increase in CD8 positive T cells. The trial design is to optimize numbers and maximize the science and understand how these drugs are working in our patients, whilst not overexposing patients when we know that we've proven mechanism or futility. So as an example, this is how the volrustomig arm, which we're about to start, will work. We'll recruit 10 patients. If we have less than or equal to 2 or more than 6 responders in that first tranche, we will move on because of futility or proof of mechanism to the next arm. But if we're in between those numbers, we'll recruit a further 5 people, and then a final 5 if needed, based on the numbers of responders, based on those primary endpoints I showed you. So a maximum of 20 in each of the arms. Obviously, these are great ways of understanding these agents and understanding these tumors in our patients. I mentioned some of the imaging approaches, but also tissue, blood, urine, multi-region sampling, co-registering of the tissue with the imaging, and of course, multiple molecular strategies which will be integrated. I think the most key thing, though, about WIRE is the vision and the possibilities for the future with this. So a number of us are quite keen to move away from single agent, single center studies that take quite a long time to set up, rather to this sort of platform where we can potentially work as a community. We can take inspiration from other studies and other tumor types. This is the I-SPY2 model in breast cancer, which is fairly similar. There are some enhancements in that model. They have a randomization. They have a real-world control. But you can start to see, if you look at this chart, the numbers of agents that have been tested. Many have graduated to later phase clinical trials. Others have been stopped in that disease because they don't seem to show the signal that you would expect. Thank you very much.
All right, well, thank you very much to all the speakers. We must have frightened everybody to being on time. Anyway, so we have time now for questions for the speakers or any other studies people want to bring up that they feel of interest to the group. So let's see, we're looking for the box for, we're looking for Tony's box for this person over.
Just throw it. Yeah, most immunogenic up to 34. You may end up with, you know, very few, and the guess is in renal, you will end up with way less than melanoma, right, Mike? No, no, is what we come up with. But there has been work before, and we can get not as much. Way less, because if you look at the melanoma study, there was like one question if it's a hit less. Was PD-1 and the vaccine from the melanoma study led to more immune-related AEs? And the answer is no. We don't know. I think we don't know overall how, and this is a grant that actually Mike and David Braun, if David is here, want to take, they're looking. We still don't know where are they coming from. I think that's one of the big things in renal cell. David? Very few are from surface proteins, so they're not. When we look at phase 1, probably 95% are from cellular, and then the ones that were surface, very few had surface epitope exposed. Like the part that was actually mutated was in the transmembrane, or something that wouldn't be exposed to the surface. So we've thought about this in the context of like, are we eliciting a B cell response in addition to a T cell response? But it's generally intracellular.
But immunologically, you think that the cell surface versus the internal peptide would be equally efficient in eradication?
Yeah, I think what we found actually so first of all, yes, I think so, because ultimately everything is being processed through HLA class 1 machinery and being presented, so I think the source is probably less important. We found certain things like expression levels, but particularly driver mutation status to be a fairly important thing. But again, small scale, so this will be important.
And there is trafficking that happens. You don't know what cell surface that doesn't become and vice versa. Oh, Tom
All right,
Pavlos.
next question.
I wanted to talk about the micro device, which seemed really unusual to me. I haven't seen this before. Has this been tested anywhere outside of kidney cancer, number one? Number two is inevitably there's going to be quite a lot of tumor heterogeneity, and the tumor microenvironment is going to be very variable. How does one account for that? And then number three is when you go in and do your analysis, how are you going to actually analyze efficacy, and how are you going to distinguish between, because immune effects a long time, and whereas chemotherapy cytotoxic drugs cause apoptosis, and you're going to see different pictures. It's not going to be black and white, death and alive. It's going to be like lots of colors of the rainbow. How are you going to account for that?
Okay, I have to remember all of the questions. Yes, so the microdevice is a novel approach. There has been previous work that has been published by the Jonas Lab, which is a Brigham and Women's lab, in animal models and also in other cancer types. So the first study that has been published is in astrocytomas, but there are also other clinical studies, for example, in ovarian, prostate cancer, and there's a bladder trial starting right now. So it's used in several different entities, but always in the stage of phase 1, so nothing further than that. And I do have some originally sized microdevices with me, so I can show them to you if you're interested in that. And also like a 3D printed model to visualize it a bit better. Okay, the second... Tumor heterogeneity, yeah, thank you. Yes, that's why we usually implant more than one microdevice into the target lesion. So I don't know if you noticed, but on the slide it said that we had enrolled 7 patients so far with 19 microdevices being placed. So usually depending on the tumor size, 3 or 4 microdevices are placed. But yes, the tumor heterogeneity is a problem. And sometimes, for example, especially in primary tumors, you have necrotic areas, and microdevices end up being in a necrotic area, which might be like less easy to interpret. But that's how we tackle this problem. And the third point,
Mechanism of action, different mechanism of action.
yes, drugs. Yeah. So that's why we analyze them in different settings. So we look at, for example, apoptotic index to account for cell death. And then we also have the cyclic immunofluorescence experiments that consist of a large panel of, for example, immunogenic markers and also cell death markers. So it's more than 20 markers in that panel to analyze the different drug effects. And yeah, we have to like consider that. For example, we also have CDK4/6 inhibitors, and as these, for example, also cause like mostly senescence and not apoptotic cell death. So this is something that we are really careful about, and that we're still optimizing the pathway, what to include in the analysis to have the optimal readout of these microdevices.
Tom,
Okay,
we're not
So
acting.
we're just, so that there's some other questions here, I just want to make sure, that we have a question for Dr. McKay, and then we're going to go to Nazar, just so we can, I think the discussion, we could probably follow up afterwards, because I think it could probably go on all evening. So, to Dr. McKay, do you know why the clinicaltrials.gov listing of Hybricell's phase 1 trial of HC7366 as monotherapy in advanced solid tumors shows that it's terminated?
Yeah, the study is closed. It was not for any mal safety signal or adverse event. It was a pan-solid tumor trial. There was very limited patients that had renal cell carcinoma that were enrolled. There was very limited activity that was actually observed in the context of the pan-solid tumor study, and the decision was to shift with a focus on RCC.
Okay, well, I think we'll take Nazar's question here.
Yeah, thanks, Bob. So, question to Dr. Grant. I like your multi-arm study, quick readout while waiting for surgery, but I didn't really see the rationale to use a PARP inhibitor. That's one. And the other question for Toni. Toni, do you have data from Catherine Wu's lab about papillary and the vaccine works in papillary? Because I saw that you have it as one of the, I mean, you're including papillary patients and you're stratifying for that in your trial, in the randomized trial. What's the rationale? Do you have that data?
So no, the papillary, it's good. It's a leap of faith because of pembrolizumab activity in papillary from David's study, Keynote 427. And it is a leap of faith and unmet medical need. But I agree with you. No, our study with Kathy was in a clear cell. I think just because we believe pembrolizumab, probably that's a way to have patients with papillary referred to us. It's a leap of faith overall.
Okay, coming back to
yeah,
the question for Dr. Stewart.
Thanks. So when we started recruiting to Wire 2 or 3 years ago, we had a nice hypothesis about the DNA damage response that you see with a number of different mutations in renal cancer, including VHL. So that was science from our labs in Cambridge, published in Nature Medicine. And that there could be a contextual lethality by adding in a VEGF TKI into that, hence the cediranib added into that. So we'll see whether that plays out in the mechanistic work that we put in. We've finished that now, and we're moving on to the translational studies from that component.
So I have a question for Mike. So tell us, why should patients go on your trial? How do you talk to them about a randomized design between this?
Yeah, absolutely. So, you know, when I talk to patients about this study, I tell them that at minimum, they're getting the best immunotherapy that we have available, so IPI plus Nivo, but you have a more than 50% chance that you'll get the interventional arm, which is what we think is going to be an even better immune therapy combination. And as I said before, is hopefully going to induce more long-term durable remissions for patients with clear cell kidney cancer. And so, you know, I have had a number of patients randomized to the control arm, and I think that's, you know, part of what we do in clinical trials. But the 2-to-1 randomization and the novel mechanism of action, I think, is really appealing to patients.
Okay, there's one question that I think hasn't been answered yet, that's been submitted, and that's for Toni. That's, do drugs like V940 potentially change the thoughts around immune checkpoint inhibitor rechallenge in patients that experience progression or checkpoint failure?
No, this is a good question. I don't know, but if anything it would be this strategy. Hopefully, first the adjuvant strategy is positive to test that again. Now, if the vaccine, we don't have a you know, an arm where the vaccine alone is tested as a trialist. This is important, although we think that, you know, you could not with pembro do that, Pembro being standard, but that's a very good question. We're collecting more data about ICIRI challenge. Tini Votu finish accrual. This is a study with Laurence and Bob and many, and hopefully it will be available this year, and it will be re-challenged with PD-1, not PD-L1 inhibitors.
Okay, I think we have time for maybe one more question back there.
Hi, this is for the ARCITECT trial. Do you think response rate is an adequate surrogate for, long-term remission and survival, which is really the main reason why we use Ipi/Nivo or, any CTLA-4 and PD-1?
Yeah, thank you for the question. I think it's an early indicator of response. To have a large randomized phase 2 trial and look for a PFS endpoint would take a much larger sample size. But I think that there is a proportional standard to Ipi/Nivo, which we're using as our kind of non-standard control in this population. But your point is absolutely well taken. We are going to be looking at those longer-term endpoints, and I think Dr. Atkins is probably going to answer the question better than I.
Yes.
Yeah, I think response is a really good endpoint for immune therapy. It's not a good endpoint for targeted therapy. I think in most studies, response rate relates to long-term survival because those responses are very durable.
All right, any other, I guess, one question. I see Laurence in the audience. Laurence, anything we should know in terms of clinicals and trials in progress on the continent?
So here, Laurence.
Wow.
Okay, thank you, Bob. Thank you, Nizar. Last year, actually, I was announcing CARE1 study, which is a frontline head-to-head academic trial that is comparing IO versus IO-TKI, investigator choice of the IO-TKI. Now the study is up and running in France, not yet in the other European countries, but at least it started, so hopefully in the coming years we'll be able to address that. We're using PD-L1, assessed locally, meaning by your local pathologist, looking at tumor cells. I think this is very important, so it's tumor cell staining, to have a rationale that in PD-L1 positive IO would do better than IO-TKI, and the reverse hypothesis in the PD-L1 negative. So the study is up and running. It's enrolling actually very fast right now.
Okay, good. That was a handoff, by the way. I knew about the trial, and I figured I'd ask about it.
Thank you, Bob.
Good job.
All right, so anyway, I think we're actually ran out of time here a little bit, but it was a great session. Thank the speakers, all the folks asking questions, and I think with that, we'll close this session.